So welcome everyone. My name is Avery Haller. I am the Executive Director of Strategy and Partnerships at Health Gorilla. I am very excited to welcome you all to this webinar today about what's next for QHIN. I'm sure many of you all of you saw the news earlier this week that we have been approved for onboarding, and perhaps some of you also watched the live stream from the HHS event. So today we are here to dive in a little more and learn more. We have three speakers that really need no introduction, but I'm going to give an overview of their resumes now and let you know what they'll be talking about. So today's speakers, we have Dr. Stephen Lane, who's going to kick us off and talk about the background of TEFCA and kind of give you a broader view of how this came about. Stephen Lane has been in the health IT world for quite a long time as a physician at Sutter, Sequoia Project Board of Directors, and also on ONC's High Tech Committee. Again, resume could go on, but I will stop there. Then Dave Castle, who is currently our SVP of Operations and former Executive Director of Care Quality, will be taking us through a look at what QHIN really means for our customers. So more focused on the Health Gorilla customer base. And then Jitin Asnani will be taking a look at what the future holds. So that will hopefully, and Jitin is a former executive director of Commonwealth, one of the founders of Commonwealth. Again, resume could go on, but Jitin's going to really take us into the future, and I hope that will spark some really good Q&A. So as the presentation flows, we are actually going to hear first from one of our founders, Steve Yaskin. And as Steve, Stephen, Jitin, and Dave are talking, please feel free to put questions in the chat. I will be monitoring the chat Q&A, and at the end, we should have plenty of time for questions, and I'm hoping for some really rich discussion. So again, welcome everybody. And Steve, I will kick it over to you.
I have to get off the mute. Hi, good morning, everybody. Thank you, Avery, for the introduction. I'm really gonna take 1 minute of everybody's time here. Thank you, everybody, for joining this exciting webinar. I am absolutely thrilled today about Health Gorilla QHIN application approval. I just returned from Washington, D.C. As you can tell by my voice, I still don't have it quite back 100%. But Health Gorilla was thrilled to accept the certificate of recognition of QHIN status from Secretary Becerra. I was excited to meet all other QHIN candidates. There's a total of 6 organizations that were designated as QHINs. Applications approved, and we are absolutely looking forward to establishing connections between our organizations later this year. QHIN to QHIN exchange is what we're going to be doing from now on going forward. And Health Gorilla initially announced our pursuit of QHIN status in late 2021. It was kind of a very hard decision for our organization, and it was a bold move, turns out, for the whole team. And in order to achieve this bold mission, I think it was absolutely necessary for us to become a QHIN. This aligns very well with the vision and mission of this company from day one. We were building this bridge between the public and the private sector. And I think QHIN strategy and us becoming an approved QHIN this year, going in production this year, absolutely follows that master grand plan for the company's vision for the whole country. I believe establishment of QHINs and TEFCA overall has really set a new standard for what it means to participate in national health information exchange in this country. Exchange must be rooted in trust, commitment to protecting patient privacy, and all the vendors must have the technology and team to support participants and sub-participants on this journey. I'm really excited about the path forward. As Mickey said, we need to start QHIN to QHIN exchange by end of this year. I think there were some corrections on that when Secretary Becerra actually said, I hope we could do it in 10 months. So our goals keep moving here, but we're very excited to accelerate the progress to go into full production mode sometime this year, later this year. And our team is absolutely ready to go right now. That's all on my end. I'm going to turn it back to you, Avery.
Fantastic. So now Dr. Stephen Lane will take us through some background.
Thank you, Avery, and thank you, Steve, for kicking us off. My name is Stephen Lane. I'm a practicing family physician and clinical informaticist, and I serve as the Chief Medical Officer at Health Gorilla. And I joined the team just 5-6 months ago, really to help support this project, to help get Health Gorilla over the line to become a QHIN, to support the Trusted Exchange Framework and Common Agreement. And I just couldn't be more excited to be here at this milestone in our journey. But of course, this journey started a long time ago. I mean, I've personally been working in the health IT space for well over 30 years, been working on interoperability for over 15 years. But really modern interoperability, as you can see on this chart, dates back about 10 years with the passage of meaningful use stage 2, and really the requirement on providers and the support of their health IT vendors to really start to put interoperability into practice. And as that started, a number of networks began to form across the community. Some of them, like eHealth Exchange, had been around for quite some time, but QHIN, as you've heard, was central to the formation of the Commonwealth Alliance and the foundation of that vendor-based network. I was very involved with the EPIC community and the formation and advancement of the Care Everywhere network. And then, so we had these networks, but there was a need for them to be able to connect, to have cross-network exchange. So Dave stepped forward as the first executive director of Care Equality, and he and I and many, many other people worked hard to stand up Care Equality, to begin building that trust framework that would allow cross-network and really nationwide vendor-agnostic exchange. And in 2016, really at the same time, or in the same year as the passage of the very important 21st Century Cures Act, we actually had the very first exchange of data under the Care Equality framework. It was actually for one of my patients with another provider who was seeing the same patient using Athena Health. And it was just very exciting to be a part of that moment in history. Of course, the Cures Act really set us up for the success that we are starting to experience today, with both the declaration that the federal government was going to support a trusted exchange framework and the use of a common agreement to be able to have a single on-ramp to nationwide interoperability. And of course, the prohibitions against information blocking, which really has freed up the data to be able to move more freely across providers and other caregivers and other stakeholders who really need to get this data to support health. So we find ourselves now at a new and very important milestone where the QHIN application process was established, it was opened, a number of organizations applied, and now 6, as you've heard, have been named to move forward as the first batch who will engage in testing. And I think we all have every intention to be finally qualified and designated as QHINs to begin production exchange of data this calendar year. That is our plan. Officially, the timeline gives us 12 months to get this work done after our applications are accepted, but all of us stood on stage earlier this week and declared that we were going to do everything in our power to get it done this year. Should we go to the next slide? So a little bit about, what is TEFCA, what is a QHIN, how does it all fit together? Again, the Trusted Exchange Framework and its supporting common agreement is really meant to provide a common set of principles, terms, conditions, and really support the nationwide exchange of electronic health information. This is very much what we've been doing throughout the industry for many years now, as you heard, but this brings the government and government oversight into the mix so that we really are assured to not only follow the same processes, but also to be able to advance use cases that we really haven't been able to advance using the private industry incentives that we've had before us. So the QHINs, or the Qualified Health Information Networks, will really be the glue that holds together TEFCA Exchange. And they are designated. Each of the QHINs have to meet very stringent requirements for privacy, security, workflows, governance. There is so much in there. And so Health Gorilla has stepped forward to be one of those QHINs. We anticipate, being ready to exchange as soon as anybody else is. And we're really looking forward to that and moving this new generation of health data interoperability forward. Next slide. So this gives you just a little bit of a picture of some of the stakeholders or participants, really, who will be involved in this exchange. So, of course, this is all with the patient at the center. The goal is to support patient care and services, whether in the healthcare space, the social care space, or simply individuals being able to get access to their own data using the individual access service purpose of use. But of course, providers like me, payers, health insurance companies, and the entire community of providers and other caregivers that are involved in supporting patients. So that includes their pharmacies, it includes laboratories that provide services, and the full community of care. And under the TEFCA framework, there have been identified 6 specific use cases that are going to be supported initially, and probably there will be more added in the future. But we're starting this year with treatment, which of course, we've had a lot of exchange for treatment historically, but also individual access services, really keeping that patient at the center, assuring that patients can access their data as needed, and then moving on to select sub-use cases within payment, healthcare operations as defined by HIPAA, and then also moving to address the very real need for improved data exchange to support public health and public benefits determination. So this is going to be a journey as we add on additional use cases, but again, starting, as we said, with the treatment and individual access services in the first round. Next slide. So here again, this dives a little bit deeper into what each of these use cases entails. I'm not going to read through this, but as I did mention, we've had a lot of exchange, really tens of millions of transactions on a regular basis to support treatment. So providers like me have pretty good access to healthcare data from across the healthcare ecosystem, but that doesn't mean that we have access to social services information, to information from non-traditional providers, or, unless it comes to us through our portals, to information from the patients. So deepening the support for treatment while expanding options for individual access services. Historically, patients have had a lot of access to information through their portals provided by their providers, but this will open that up to use the new FHIR-based APIs to really facilitate patient access. And then, as we say, as time marches on, we're going to focus on payment, healthcare operations, really trying to get at those other HIPAA-supported use cases, and then moving on into the areas of public benefits determination, which really has to do with federal or state governments deciding whether a person is eligible for benefits, which is critical both to the individual and to the healthcare system. And then, of course, public health, we are transitioning from pandemic to endemic with COVID-19. So many opportunities have been identified to improve public health data exchange, and we certainly want to see that supported by CDC and others using the TEFCA. Next slide. So I think this is where I pass it to you, Dave. Is that correct?
I believe that is correct, yes. So we want to, excuse me, I was also just in DC, and apparently we all should have taken another day to recover our voices. But wanted to shift a little bit into what this really means in terms of what we will now, well, I should say when designated and if designated as a QHIN, we will be able to offer to our customers, and what in general this ecosystem offers to healthcare organizations. So there are 3 points here that I'm going to go through, and unfortunately they're all inextricably intertwined, but I will try to extricate them and talk about each one separately. And the first one, though, is exactly that same theme that Stephen has been touching on over the last few slides, which is unlocking these new use cases. And to take a step even further back, each of these 3 points represent areas where all of that great work that we have done in the private sector, sort of organized organically by the industry, has, if you sort of picture the wave that runs up against the up the beach, eventually it just hits the tide line and it doesn't go any further. And you need to raise the level of the water before you get any further up the beach. And that's really what we're seeing here with TEFCA in 3 specific areas. Despite my best efforts and Stephen's and Jitin's and a whole host of others, there were just some areas that we weren't able to unlock in that organic private sector driven exchange. Despite all the good that was done as well. Stephen alluded to the many transactions that occur today for treatment purposes, and I'm very proud of my role in that. The QHIN really is going to raise that water level, if you will. And the first is, as Stephen has been saying, unlocking these new permitted use cases. I don't think that we're really going to see progress there in a reasonable time frame without the government's both approval, sponsorship of, and incentivization of participation in those use cases. So if we want to jump to the next slide, the next point, and again, these are all definitely intertwined, is that there's a certain segment of the market that we've just never quite been able to reach for various reasons in the organic private sector approach to interoperability. I think the number that was used on Monday in the QHIN presentation ceremony was 30% of the providers, the markets. I'm not sure exactly what they're defining there, but there's about 30% of the world or the country is not being connected. And we need to find a way to chip away at that. And QHIN is going to be able to do that. As these other factors, including the availability of new use cases as a draw, and the participation of government and the incentivization by governments as a lever as well, will drive that additional 30% forward. So if we jump to the next slides, and I'm kind of moving through them quickly because again, they're all pretty intertwined here. But let's pause for a little bit now on this slide and the heightened trust, because this ultimately is the crux of it. In order to raise that water level, and I'll probably overuse and mix some metaphors here, we also needed to raise a bar for those who are actually operationalizing connectivity. There is a very rigorous process that goes into the QHIN world, and we're still in the midst of it. We have not reached the end of that process. We've gotten through one gate, and there are some others that are still ahead of us on the way towards QHIN designation. But there is a very rigorous process, and we're going to come out of that, I think, with greater trust. This isn't to say that care quality and Commonwealth are not trustworthy. But there's just an additional raising of the bar that is needed in order to fully bring into the fold the government agencies who then will be able to incentivize, will be able to apply policy levers, will be able to participate themselves in these exchange activities due to that heightened trust, the greater security, the greater protections for privacy that are all there in the operational controls that the QHIN process is going to provide. So by establishing that raised bar, we're going to enable greater participation by more organizations, by federal agencies specifically, and state agencies, I think, are going to end up coming along as well. But in terms of nationwide scope, the real drivers, I think, are going to be that federal agency participation and incentivization. I think it's reasonable to think that is going to start with CMS, But there will certainly be others as well, ranging from the CDC, the Department of Veterans Affairs, the Department of Defense potentially getting involved in sharing records for military personnel and their families. All of these different players, and no doubt others that will pop out of the woodwork with different use cases that make sense from a government standpoint, are, on the one hand, going to drive more demand by participating themselves, but also are going to drive participation as well through all of their many different regulatory and policy levers that they're able to pull in terms of referencing the QHIN ecosystem. So a lot to absorb there, but at the end of the day, again, we do expect the QHIN ecosystem to result in broader availability of a lot of different use cases, no limitations, ability to access this widespread exchange for a lot of different reasons, a broader pool of participants, and ultimately a raised bar that will give greater confidence in the security, the operational governance, the patient privacy. And again, all of those things are intertwined and they all feed into one another in a virtuous cycle. In terms of, one other last point, in terms of what to expect for Health Gorilla customers specifically, I know there are a number of you on the call today. We're still in the process of going through designation. We are going to certainly begin working with you and starting to help you with what it means to onboard as a QHIN participant prior to then. We will specifically at the right time be looking to have our customer success managers reaching out to each of our customers. We want to try to time that in a reasonable way so that we're dovetailing that into the onboarding process that we're going through ourselves. But one thing to keep in mind if you want to start doing some preliminary homework is that you will want to be prepared for some additional terms that will be required by the QHIN ecosystem. We're implementing that as an addendum to your contracts. So that's something that you can at least start to prepare the groundwork for as we look to move forward here with actual implementations. And sorry, with that, go ahead to the next section.
Yeah, fantastic. Thank you, Dave. And I just want to, before Jiten takes the mic, I just want to remind everyone, thank you for putting your questions in the Q&A. We're getting some good questions in there. After Jiten speaks, we will move to Q&A. So keep putting those questions in and we'll gather them and answer them in a few minutes. Thanks.
All right, awesome. So far, Stephen Lane has led us through kind of how we got to this moment, and Dave kind of shared what the implications are. What I'm going to do is I'm just going to help us like pan forward the camera a little bit over the next few months and inching into next year, so we can start looking at what the future is going to hold over here. So we're designated, we have an approved application. As Dave mentioned, we're going through this process of being designated. So what does that mean? What's kind of happening behind the scenes in a nutshell, right? To the extent I can share. And it's really kind of two things that are happening. First of all the QHINs who were announced this past Monday are in various stages of actually having their QHIN functionally ready, right? There was some amount of leeway they had to get in terms of technical project planning to get themselves across the line. We're quite far ahead of relative to most, but everybody has some amount of work to do there. So you can imagine that over the next few months, that's the kind of work that is going to happening behind the scenes for each of the QHINs. The next immediate step is testing and implementation. Really, testing means against the tools that the RCE, who is a coordinating entity that sets these rules that the QHINs have to abide by and then flow down to all of their customers. The RCE has their own testing suite against which we're working, as well as, of course, QHINs testing against each other. The funny thing, of course, about interoperability, and it's true, unfortunately, everywhere in the interoperability world, is it always takes two to tango. So we think we're going to be pretty ready to start testing pretty early, but unless we have somebody else to test with, it might be a little while before we get there. In any case, as Stephen mentioned right at the beginning, everybody is committed to being done by the end of this year, in 2023. I have a suspicion we'll get done a little bit sooner than that, but it is interop and it's tech, and you don't know what bumps you hit. But it's looking pretty good in terms of those being the steps before we can start onboarding customers, and every QHIN can start bringing in their participants so that we can start doing real live data production exchange. So that's what's happening right now in terms of panning forward the camera to from Monday to today and the next few weeks. I think everybody took Tuesday off, by the way, coming out of the Monday kind of marathon session in DC. So really, it's really today that everything is this kind of diagram has really kicked into gear. The next step is hopefully fairly clear from there. Health community will start gearing up for participation. I think there are going to be two linchpins to this. The one that's obvious is we have across things like Commonwealth and eHealth Exchange and Care Equality and Health Gorilla's own network and other networks and exchanges that happen across the country, we have participants who are used to this mechanic of data exchange. And they hopefully will get it and start signing up relatively quickly. And in some sense, what a number of these organizations, like Avery mentioned at the beginning, I was a founder of Commonwealth, getting the first few sites live was a tremendous ordeal. And then the flywheel sort of started. I think over here, we'll have a bolus that can start, hopefully will start right away, the moment things are live, because they're building on something we already know. But what I'm really excited about is others who start for the first time have direction in terms of where the country is going, and no longer have to feel like they're confused by many, many different options. They'll have to pick a QHIN. Hopefully they'll pick our QHIN, but at least they know that once they're in, and now they can exchange. So I'm very hopeful that 30% of hospitals who are not connected, and I think Paul Wilder, the current executive director of Commonwealth, said there's 65% or 70% of ambulatory and post-acute is not connected to anything either. I'm very excited that they will start joining this kind of next step. And as that happens, we'll get into the third step. In fact, we've already seen some early shoots of that third step where incentives are going to kick in to encourage broader participation. I think Stephen mentioned that at the event in DC this past Monday, where all of this was announced, we had several federal agencies come on stage and talk about what TEFCA means to them. We had the VA and CDC, the CMS, and I'm sure there's some others. And that's all they could fit probably in a 45-minute span of having them come up on stage. And I'm sure there were others who would have lined up behind them. They're incredibly motivated. Indeed, like I said, there's some early shoots that CMS has shared already publicly about what might be coming, and I'm sure there's a lot more that they can't share with us. But CDC has been almost public about how much their future plans are predicated on the success of TEFCA. So I'm really excited that the federal agencies will bring their convening power, bring their other levers to the table to help get us really going here. On the topic of incentives, let's go to the next slide. Like I said, there's an early shoot, and just in case you missed it, hopefully for provider organizations out there, you're already well aware of this. But if you're not, and certainly if you're not a provider, early last year, CMS updated their IPPS rule, right? And their 2023 IPPS rule shared that there is a new measure available for satisfying the health information exchange objective. And the health information exchange objective is worth almost a third of all the points that get driven into that incentive criteria. The first two have been left unchanged. And for those who are not familiar, one of them is to report on two measures: the support electronic referral loops by sending health information, and support electronic referral loops by receiving and reconciling health information, which, in addition to being a mouthful, is actually quite a bit to measure and keep track of, and a hurdle. The second one was report on HIE bidirectional exchange. This does have the advantage of being much easier to say, but it only works if you're in a community where you can actually do bidirectional exchange with an HIE. And if you're multi-geography, you have, again, a lot more administrative hassle you have to go through. The new option that they added in was to report on enabled exchange under TEFCA measure. And this just basically means that you have connected to a QHIN. And at least for the calendar year version of the IPPS rule, the calendar year 2023 version of this rule, that is incredibly easy. That's an incredibly easy step to take to ensure that 1/3 of your incentive points are like met immediately. I'm sure they'll add to it over time, and for those of us who are looking for incentives and are looking to see how we drive that increased participation, not to 70% of hospitals or 25% of non-hospitals, but to 100% of both, you can see that this is going to be one avenue that CMS takes on both the hospital side, in this case, it's specifically on the hospital side, but also on the ambulatory and post-acute sides to get strong participation. And so let me wrap up with this, just taking a view, zooming out in this last slide. We've, for those of us who have been in the business of building networks, and I've built networks in 2 different industries, the most recent being health IT, but there's a flywheel that you always see. It's slightly different buckets in the flywheel, depending on what industry you're in. But here in healthcare, we've seen this flywheel before. Dave saw it when he built Care Equality. I saw it when I helped build Commonwealth, where we'll first start with a number of participants who join in, who understand what's coming, who get it, who have, who understand that they can get over whatever minor frictions, and hopefully it's relatively minor frictions, to start getting involved. And they start exchanging with each other, and the volume increases. In the meantime, others pay attention, and particularly, for example, if a set of hospitals joins in, then all the non-hospital settings, the ambulatory, post-acute, home health, SNF, et cetera, patients themselves and the like, they also start joining in. And so you have this effect, and this is the effect we saw at Commonwealth, this is the effect you saw at Care Equality, where there will be this beautiful exchange, increase of exchange that happens just because more participants are joining each other. And it's a very classic 2-sided network effect. Over here, of course, we have a third, the tailwind that actually dramatically changes the picture and increases the flywheel effect. And that's the incentives that, now all 3 of us have mentioned at some point. And like I said, we saw the early shoots with that IPPS rule. There's going to be a lot more to come here. Just the participation from the federal agencies themselves is going to be a huge set of volume that comes to these networks as well. And I think what we'll see over the coming months, and certainly in the coming years, is this really rapid adoption and hopefully, achievement of the ONC goal of seeing health data exchange happen for not most of the country, but all of the country, and not for 1 or 2 use cases, treatment and individual access being the safest 2 that provider organizations have gone to in the past, but across all the use cases that we should be going after, all of HIPAA, TPO, public health, benefit determination. I'm sure there'll be others after that as well. And if we get the full breadth and the full depth of those use cases and that scope happening, then we really are taking another big step on the path to national interoperability. And so, this is an incredibly exciting time. If you are examining the landscape to finally have a direction that you can finally go to and know that's going, and to actually participate as national interoperability becomes more of a reality. All right, Avery, I think I'll pass it to you. I hope we have some more questions in the Q&A to go through.
Yeah, thank you, Jitin. Thank you to all of our speakers today. I learned more today, and I hope everybody on the webinar learned a ton. We have some great questions, so I'm going to jump right in. I'm going to kind of answer these in buckets because there are some common themes. So there's one quick clarification question, and then we're going to talk. So it seems like there's some questions about, Health Gorilla, our differentiation as a QHIN, and also what's happening with some of the other networks. And then I'm seeing a third bucket in use cases. So we'll dive into some specific use cases. So first, just one clarification question that Lynn sent in. Are you referring to FedRAMP when speaking about trust and government requirements? So FedRAMP is separate. There are specific requirements as part of the common agreement, part of the trade exchange framework, so part of TEFCA and part of the QHIN program that we're referring to. So FedRAMP is separate, but also another great example. And just on the security note, we also are, as part of QHIN, we will have our high trust certification as well. So multiple increases in our security infrastructure. Another question that I'm seeing, and this is a common theme, is not all QHINs are going to be created equal. How are people going to choose? There are a lot of standard pieces, but there are some differentiators. How is Health Gorilla differentiating itself? And what happens to those networks who ultimately aren't successful as QHINs or aren't chosen as QHINs? So let's start with the differentiators for Health Gorilla.
Some of the QHIN candidates are trade associations or membership organizations that are beholden to obviously those groups. Whereas we are a neutral player, we're able to execute for our customers as the demand arises. Steve alluded to our technical platform. One of the reasons that we're able to build that and to adapt it as well as we need to going forward is that we are as a for-profit company, we are relatively well capitalized compared to some of the others that are nonprofit organizations that just don't have access to the resources that we do on that front. We also have a set of additional products so that if you come with us, you will have access to other things, and you can build on that relationship with our other products and services beyond the healthcare interoperability piece. So just a few additional things to point out there on terms of that differentiation.
Can I just add in? I think Dave mostly said the point I was going to make, but the way I think about it when I'm advising clients is first start with the job you're trying to solve, and then look at the tools you're going to get from your options and see which one actually makes the most sense for that problem you're trying to solve. At the end of the day, when you get the data from Health Gorilla, it's a consolidated report of the data. It's a longitudinal record. It's not a stack of CCDAs, which is what you can often get when you're engaged in sort of upstream, just pure data exchange, where you just want to see the data move around because that was the big problem to solve at one point. And so you have to scale. What's the problem I'm trying to solve? And does the vendor give me the tools within that exchange, as well as any ancillary tools that I might want to use in order to actually solve the problem? Because nobody's, except for those who are specifically going to check a box, nobody's exchanging data just to exchange data, right? If you're trying to take care of a patient or get paid or go through a healthcare operation or whatever the case may be. And so, that's where the variety is actually super helpful, because people will have different jobs. And it's good to have different options.
Yeah, and I'll just add, and I think perhaps restating what Jitin was saying, one of the key differences between the QHINs is whether they are simply providing a pass-through of data or whether they are actually aggregating that data to create a longitudinal record. Certainly, some use cases, some participants, want to have that benefit. Others may already have that covered, in their EHR or their billing system or what have you. They may already have all the data they need, and all they need to do is move it from point A to point B. So that's one way in which the QHINs will be, very, very unequal. Some are proudly pass through, and others are, firmly committed to enriching the data, receiving it from multiple sources, normalizing, deduplicating, mapping, in making that data more valuable when it passes between participants.
Absolutely. And if I could kind of sum this up as we move to the next question. At the end of the day, I am seeing some questions in the chat about, wait a second, isn't QHIN to QHIN exchange free? Yes, QHIN to QHIN exchange is free. We want data to follow the patient. We want everyone in the nation to be pulling from the same pool. It's the value-added services on top that you would be choosing as you look towards your QHIN. So as each of our speakers has brought up, there are various value adds that you'll need depending on your use case, and that will make your decision on which QHIN to join. The next kind of related question is, what happens to all the networks that exist today? So Jitin, maybe let's start with you, and then Dave, I'm sure you have some thoughts, as well as Stephen Lane.
So there are a lot of different types of networks that exist today, right? So the fate of each will kind of be dependent. But if I had to pick maybe 3 categories, and there's probably more, but I'll pick 3. Mainly because I'm an ex-consultant and I do everything in 3s, and that's as far as I can think anyway. Category 1, those who will become QHINs, and it makes sense for them as a business. They have the tech to do it, they have the governance to do it, and it's either a no-brainer or it's worth the investment to get there, right? And so that's category 1. Obviously, we are squarely in that category. Category 2 are those are for those who need to participate in TEFCA. It will make sense for them to participate in TEFCA, but it may not make sense for them to become QHINs for a variety of reasons. It takes a lot of investment. There are quite a few hurdles in becoming a QHIN, and then the volumes you have to deal with are just operationally beyond what most tech vendors expect. It is dramatically more. If you think about 1.1 billion patient encounters in acute and ambulatory settings, you multiply that by, I don't know what the number is to get to post-acute, and you multiply that by another, I don't know what the number is to get to all the different use cases. You're talking about billions and billions and billions of transactions that you have to support whether or not like that patient was actually relevant to your customer, right? So it's a fair investment. For those participants, I see them just joining with other QHINs. I think there'll be a number of great networks and entryways and on-ramps that get you into one of these QHINs by virtue of them being participants, right? And there's nothing that says you have to be directly connected to a QHIN. There's advantages to doing so, of course, but there's nothing that says that that's the only path forward. And then the third bucket are those who were trying to do this and we're doing this at subscale and are not able to evolve. Hopefully that's a very small bucket, but I do expect that across the industry, those players who find themselves squarely in the, affected by this will either have to migrate to doing a different job or just suffer the consequences of not realizing it because TEFCA is very much kind of rolling forward. So that's the way I would think about it as a realist.
Thank you. Dave or Stephen, anything to add?
Yeah, I would agree with Jitin, and not really a whole lot to add in the interest of getting to more of the good questions.
Fantastic. All right, let's move to some use cases. So we had a question come in about individual access and some examples around individual access. Stephen did provide some answers in writing, but I wanted to make sure we talked about it. So the individual access service is very important to Health Gorilla. We really want to make sure that data follows the patient wherever the patient wants that to go, including, facilitating organizations' ability to allow the patient to come in and send their records wherever they want. Stephen, could you elaborate a bit on some of the individual access use cases that you see from TEFCA as a whole?
Absolutely. Yeah, I think that individual access really falls into two main categories. One is where the patient themselves is trying to get their data, and the other is where the patient provides authorization or consent to another entity to get or transmit or use their data on their behalf. But in both cases, you're putting the patient squarely at the center. Again, when we exchange data for treatment or payment or healthcare operations, those are the HIPAA permitted purposes. The patient does not need to direct that. We just do that as in the process of taking care of people. That's how our modern healthcare system works. The patient access is a different thing. I actually was personally part of a small group that stood up the very first EHR-linked patient portal over 20 years ago. And so patients have been accessing their electronic health information since 2021, or maybe it was 2020. I'm sorry, 2000. 2000 was the year that we started that. Sorry, got my decades wrong. Anyway, so the patient access is a thing today, and then over the past 5 years, maybe or so, we've seen the onset of the use of APIs, application programming interfaces, and patient apps for gaining access to information. So, probably the most widely used is Apple Health, but there are many others where a patient can get an app on their phone, point it at the sources of data, be they labs, be they medical providers, et cetera, and download a copy of their data to their device, and then have a copy of it, utilize it, let other apps work on that, et cetera. So those are really the two main types of patient access. And what we're talking about here is really the latter. Again, portals will continue to exist. Providers and others, labs, payers, et cetera, will make those available. But patient access under TEFCA is really so that patients can go in and either say, give me my data, or here's my representative, let them have the data. And that's going to open up or unlock, as we say, all kinds of new use cases. I mean, research is one in particular where individuals have a hard time finding and participating in research trials, in getting their data to the researchers, because they need to sign an authorization and an informed consent. And all of that will start to be managed. When you apply for benefits, for life insurance, for public benefits, there again, the patient directs that access. But today, much of that access occurs with signed documents, with faxes, et cetera, just starting to move towards electronic. So you saw this public benefits determination as yet another use case that's coming down the line. But again, patient-directed access is a key part of that. So individual access services will be kind of our first foray into this. And you should think about it as patients being able to access their own data initially, and then being able to direct access by others.
Fantastic. Thank you. The next use case that we're being asked about, Michael asked, we're on the backside of a pandemic. How would QHIN be of benefit in helping the CDC and other public health organizations? This is an extremely important question. As was mentioned earlier, the CDC was actually at the HHS event, was very excited about TEFCA. Right now, exchange between public health entities and healthcare entities is very clunky. And over time, the hope is that TEFCA is going to smooth out this exchange and really create the true bidirectionality that will impact us all at a community level. Stephen, any other thoughts on that one? And
yeah,
Jay, free to chime in as well.
I put a bit into the answer for that question, but I've been involved in a number of efforts over the course of the pandemic with state and national public health agencies, really challenged by the current state of public health interoperability. And as you said, Dr. Walensky, joined us on Monday, spoke very enthusiastically about the opportunities for CDC and public health generally to be able to benefit from the kind of standardized exchange and connectivity that TEFCA is going to put into place. So I think that, we providers have really been challenged by different kinds of reporting demands, different needs for data exchange, and different definitions of how that should be done, what data should be included, et cetera, over the course of the pandemic. So to see that there is going to be this standardization, that CDC is going to participate in defining is really very important. There are other standards that are also moving forward in parallel. We haven't talked about it, but the US Core Data for Interoperability is another piece that came out of the 21st Century Cures Act, where that continues to expand on an annual basis to include more data classes, data elements, data specifications that all systems must be able to exchange. So the TEFCA does point to US CDI a bit insofar as when we exchange documents, those documents need to be able to contain, the earliest version of US CDI. But I think over time, what we will continue to see is that all these federal initiatives continue to be coordinated, whether we're talking about the CMS incentives for providers, the ONC requirements on health IT vendors, what we're going to see out of NIH, out of CDC, FDA. It seems very clear that all of these are going to converge on TEFCA as the common framework that is going to support data exchange to meet this multitude of use cases.
This is Jim. I don't think I can say it any better than that. Maybe what I will add is that if you think about directionally, that's absolutely true. We've gotten only bits and pieces so far of some of the things CDC is planning, and I'm sure there's a bigger picture and a bigger tapestry behind this, but we've already heard a few things, right? So Stephen alluded to the US CDI, where you can specify and better specify and add data elements that would be required in the documents that we already exchange today in healthcare, right? The CCDA being the typical document that we exchange, and FHIR-based resources as well. We know that Miki Tripathi talked about this at a conference in December, that CDC is making a big investment in replatforming immunization registries and how they collect data there. And you can imagine a single connection to that for nationwide immunization registry access to the TEFCA ecosystem can just drive huge efficiencies. And then there's nothing saying that there can't be bespoke documents that become required over time as CDC and CMS and others require certain types of data collected from or for patients to be made available in EHRs. And then enabling those documents to move it's actually a no-brainer. Just let them flow via TEFCA as well and allow everybody to be able to recognize those documents flowing. So we know that there are already several pieces in play, and exactly how it'll come together, unknown, but certainly there's a lot of investment there. I'd say that CDC is almost predicating their future approach on the success of TEFCA. So there's quite a lot of momentum there.
And to both your points, we're really in this moment right now where we are reweaving the fabric of health data exchange, which means that all the possibilities are open. There will be use cases that we can't even imagine today that will be made possible because that fabric is better set up. So, and that's where I'm really hoping, some of the innovations in public health will come in these places where we don't even know yet. Next use case that we are asked about, talking about the payments node. What can we expect in terms of insurance validation and payment processes? Rosa, I'm not sure if you're referring to prior authorization processes. Feel free to put more into the chat, but this is where I think we can start talking about, again, some of this interagency work. CMS is obviously pushing a new prior authorization rule in 2026. And I would imagine that the final rule is going to be woven in with TEFCA. Dave, did you want to?
I would just elaborate a little bit that there, treatment is, we sometimes think of it as being this monolithic thing, but there are actually hundreds, thousands of use cases that fall into treatment as a HIPAA purpose for exchanging information. The same is true of payment and of operations. And I think that what you'll actually see is not an across the board all at once. Anything that you might ever want to do for either payment or operations is enabled. I think you'll start to see prior authorization becomes enabled. Eligibility processes start to become enabled. I'm blanking on Dr. Lane actually has a fantastic list of these use cases, and I'm blanking on it at the moment. But I think you'll start to see incremental processes or progress rather on each of those use cases over time. And just so folks are prepared for that, I think you will see care coordination from a payer standpoint and prior authorization very early on in that process. I'm pretty optimistic about those two being not too far down the road here.
And the RCE really is driving that. They will be specifying, they're in the process of determining what will be the very first sub-use cases under payment and healthcare operations that will be required under TEFCA exchange. I know we're running short on time, but I haven't seen any questions specifically about FHIR, the Fast Healthcare Interoperability Resources. Jiten commented on the fact that much data is exchanged today in documents and some increasingly in FHIR, but TEFCA does specifically have a roadmap for how FHIR will be implemented over the TEFCA framework, how it will be used initially to specify the format of the data that's being exchanged, as well as over time, the process by which the data is exchanged. As a FHIR native platform, Health Gorilla is very well positioned to participate in that. We are already involved in the testing, with other QHIN candidates to test that functionality. So I think that we're really looking forward to seeing TEFCA as a tool for advancing FHIR-based exchange, which again is going to unlock additional capabilities and efficiencies to data exchange that we don't have today.
Yes, thank you, Dr. Lane. With that, as you said, we are running short on time. There are still a ton of questions that we haven't gotten to yet. We're going to round those up and look at putting together answers for you all. The webinar will be, it has been recorded and it will be sent out via email. And so the last thing I want to end with is any last words from our panelists, from our founder, Steve Yaskin. Open floor for the last minute here.
I think it's really exciting to see this moving forward, and personally and selfishly from my standpoint, and looking at it from our customer operations, really looking forward to working with our customers to make this an operational reality. We have a few steps that we need to take before then. As noted, we don't want to get ahead of ourselves. We're not yet designated, but we're on that path. And personally, I'm pretty confident that we'll get to the end of that path with a great outcome, and looking forward to working with our customers on it.
And I'll just say, from the clinician standpoint, clinicians have enjoyed tremendous benefits of interoperability over the last 10 or 15 years, but there are clearly so many opportunities to improve that, to improve the exchange of data with other caregivers, with the patients themselves. And I think TEFCA really is going to give us the platform to move that forward.
I'll add in that especially this panel consists of people who have put a lot of blood, sweat, and tears into many of the previous iterations of interoperability and advances on interoperability that have gotten us to this point. And so one, I want to pay homage to those efforts. Those efforts were important. I'm really proud to have been part of some of them and to have worked with these gentlemen as well on some of them. And I'm really excited to see TEFCA and this QHIN approach and the work we're doing specifically at Health Gorilla be a very large part of the next set of steps that gets us up that mountain to the summit of interoperability. So that's what I'll, end my comments with.
Fantastic. Well, thank you again, everyone, for joining. We will send this out via email, and I hope you join us for future webinars. Thank you.